So Dr. Uché Blackstock is an emergency medicine physician, and she's also one of the nation's leading voices on health disparities and equity. She spent 15 years in academic medicine, most recently at NYU Langone, before leaving at the end of 2019 to launch her company, Advancing Health Equity. We're going to spend a lot of time talking about that, so I'm not going to describe it yet. But I do want to say that Dr. Blackstock appears frequently in the media. Whenever I turn it on, I see her on CNN, MSNBC, Yahoo News, and also she testified before Congress about the racial health disparities during COVID-19. And just this week, to show you how lucky we are to have her, she was on a call or on a video, a Medscape video with the one and only Eric Topol and Abraham Verghese. Many of you must know he's cutting for stone, and so we're so lucky to have you, Dr. Blackstock. One last thing, she is a graduate of Harvard College and Harvard Medical School. And I actually wanted to start there because you've got a very interesting story around Harvard Medical School, your twin sister and your mom. So would love for you to tell the audience a little bit about that and how that also influenced where you are today.
Well, thank you so much for that really lovely introduction, Bunny, and I'm so excited to be here with you and audience and to hear questions later on. And so just a little bit about me in that context. I'm talking to you all from Brooklyn, New York, like where Bunny is, and I actually grew up about 15 minutes from where I am right now in Crown Heights, Brooklyn, but also my mother, who was the original Dr. Dr. Blackstock, also grew up near here. And I think what is so unusual is that, only 2% of physicians are Black women. And so to be a second generation physician, to have my mom, also been a physician is actually quite rare. We actually are the first Black mother-daughter legacy from Harvard Medical School, which I say as a tribute to my mom. I'll share that, she passed away when we were in college from acute myelogenous leukemia. But what my mother did was, even after going to Harvard Medical School, she grew up in, before that, she grew up in poverty. She was the first person in her family to go to college. She went to Brooklyn College and had a chemistry professor there who really saw her potential and her drive and her work ethic and suggested that she apply to medical school. So she applied to like 10 medical schools. She got into all of them because she was brilliant. And she ended up matriculating at Harvard Medical School. But after that, she came back to Brooklyn, to the neighborhood where she grew up in, and she worked here for many years before her death. And she took care of patients who were her neighbors. She mentored junior faculty as well as medical students of color. And so what I learned from her is this obligation that I'm not here on this journey called life by myself, that I actually have an obligation to my community of people who have supported me. And that was sort of one of the inspirations that involved in starting my organization, Advancing Health Equity.
I'm really happy to hear that somebody encouraged your mom, because oftentimes it's the exact opposite that happens, right? That people discourage people from.
Well, she did have she did tell a nun in junior high school that she went to a Catholic high school, and she told a nun that she was thinking about becoming a physician, and then told her in 7th grade, most likely you'll just be able to become a social worker and not a physician. And mind you, I have tremendous respect for social workers, but again, sort of limiting the opportunities of, that she could, really accomplish.
And the
possibilities, yeah.
So Uché, you wrote a really important piece in January in Stat about why Black doctors like me are leaving academic medicine, or faculty positions in academic medicine. And I think that sets up the whole story incredibly well. I've read it several times. It's very impactful. So can you talk about why you wrote it? What was it like, or what's it like to be a Black woman in medicine, and why you ultimately left?
Yeah, I will say, when I wrote that piece, and it's interesting because I think there are a portion of people who read that piece and they realize that when I wrote it, I was so sad. I wrote it like in tears because I never thought I would leave academic medicine. Like that's where I love the environment. It's incredibly stimulating. I love teaching medical students and residents. I enjoy learning from my colleagues. There's a lot of, research, clinical work going on that, that I felt like would develop me. And I was promoted last year to associate professor. So, it was, when I told people that I was leaving, they were shocked. But, really what happened was I started doing diversity, equity, and inclusion work. I was handpicked to be a leadership, a faculty director in our Office of Diversity Affairs. And, maybe I was naive, but I thought that I would be able to have some freedom to do what I thought was right and what was needed. And I think what happens in a lot of institutions and a lot of organizations that have a traditional, sometimes conservative culture, that is medicine. I think that, for me as a Black woman, I could not speak up. I could not be honest about, what were the issues. And I was actually almost like silenced and muzzled. So like all of our programming, all of our newsletters had to go through our leadership. It doesn't look like me. And they felt that it was, too inflammatory when it actually wasn't inflammatory. It was the conversations that we need to be having. And so, once I realized that I couldn't do this work authentically, I said, I have to go. And I have to go, and I'm good. Actually, I'm leaving academic medicine. I was offered associate dean for diversity at Harvard Medical School last fall. And people are like, you gave that up too? And I said no, because I think that I can take my own path and I can work with these organizations. So I still am working with academic medical centers, but externally, where I can actually say what I want to say, be as bold as I want to be, and really push them to change culture, because that's what needs to happen. Because what we're seeing is that when you have organizations that have inequitable work environments, right, where people there's a culture of fear, people can't speak openly, people of color are not staying, they're not being promoted, they're leaving, that actually has an impact on the care that you provide. Right, that we know that a diverse workforce is important to addressing and eradicating racial health inequities. And so if we don't have a supportive work environment, right, then we'll never be able to reach the goal that we want to reach.
So on that, health equity now, we're talking about it widely. Can you define what that really means, what health equity really means, and also healthcare disparities?
Yeah, and I think, so what health equity is what I think anyone working in healthcare, not just a clinician, wants for everybody, and that's for everyone to attain their highest health potential possible, right? We want everyone in their best health. And what health inequities are differences in health that are created by social, economic, and environmental disadvantage. And when I say that is actually man-made, human-made, as a result of social and economic policies. I can, when we talk about health inequities, we actually see that there are policies from the 1930s, like redlining, right? Like the GI Bill.
Why don't you explain what redlining is? Because
sure, yeah, and I'm sure there are people, on the call today that have heard of redlining and probably know it well. But I think that what people need to understand is that there were policies that were generated by our own government that have actually impacted the health of communities, even decades later, almost a century later today. And so what redlining is, it's part of came out of the New Deal, which was, in the 1930s, FDR, there was a series of programs and public works and initiatives to help Americans recover from the Great Depression. And out of that was created the FHA, the Federal Housing Authority. And so that agency was actually responsible for creating this policy called redlining, where neighborhoods were actually graded A, B, C, or D. The D neighborhoods were the red ones, A was green. And these neighborhoods were graded based on sort of, one of the factors was based on who lived there, what were the racial and ethnic composition of those neighborhoods. The significance of this grading was that it impacted the ability of someone living in that area to acquire a federally backed mortgage or mortgage insurance. And so I will say the Richmond University has really a great website. You can pull up redlining maps from any of the major cities. But actually what we see now is neighborhoods that were redlined in the 1930s. And they have the original documents on this website.
Yeah.
It's fascinating. But those are the same neighborhoods that in current day have, the shortest life expectancies, that have the highest asthma, diabetes rates, the highest infant mortality rates. And so that's not by design. I think you probably have heard of this difference in zip codes, like, zip code can actually determine your health. Well, that is because of the impact of these policies on our social determinants of health.
It's incredible. Yeah, I was going to mention the term, which people use a lot, social determinants of health, but it all emanates, right, from policies. So with respect to what you're doing now with your organization, what kind of services, education are you bringing, and to whom?
Right. So I am working, as I mentioned, with medical schools, but also healthcare systems, healthcare startups around, I don't just do talks like this, but I also do trainings around health equity, around racism in healthcare. So I'm giving some historical context for how we arrived to where we are now and how that influences the social determinants of health and what we need to do to get out of this. But I also do racial equity culture assessments for organizations, right? To see, what is the climate really like within your organization? And I also provide recommendations, as well as performing what I call equity audits, reviewing policies and practices, hiring, retention, promotion, policies for organizations who really are concerned and want to prioritize, creating an environment where a diverse workforce can be nurtured.
When we did registration, we asked people for questions, and somebody wrote in a very good question, which I want to add, which bears on this, which is, in the training that you're doing, I imagine there are a lot of white people and white men in the, in the audience, as well as non-white people and men. What do you get pushback when you start talking about these issues? And if you do, what kind of pushback is it?
So I really try to go, especially with my trainings, I really try to go in with, I talk about growth mindset, right? Making sure that people are acknowledging that the information that's being presented to you is going to be new and hopefully you'll be open to it. But I think also, I give a lot of historical context, and history is history, right? And we have a lot of data that supports sort of what we're seeing right now in terms of racial health inequities. And so it's not often that I get pushback, but I was sharing with you earlier that I had a training yesterday at a very well-known healthcare institution in the city. And, I did get pushback, and, I get pushback talking about historical points, like Marion Sims, who is the father of modern gynecology. His statue was actually in front of the New York Academy of Medicine, but it was taken down last year. He's a very controversial figure who basically experimented on women who were enslaved. But I essentially had people in the audience try to tell me that, but he was a good man. And it's not about him being a good or bad man. It's just that we need to hold space for the fact that, yes, someone could have made these really wonderful contributions to medicine, but they could also have done it in a very horrifying, egregious way.
Well, on that note, when you and I spoke before, we talked about Tuskegee, right? And I think one thing that we've seen from the past few months with COVID is obviously the health disparities are rampant in communities of color. And we also see that sometimes there's a lot of reticence, right, to go into the traditional healthcare system, right? There's a lot of mistrust. Can you talk a little bit about Tuskegee and how that impacted it and where that leaves us today?
Sure. Yeah, definitely. I mean, in a lot of my talks and trainings, I go over this this timeline to show that this distrust that communities of color, have towards the healthcare establishment, and even participating in clinical trials, that it's really based on these historical occurrences that were quite significant. So you mentioned the Tuskegee experiment, and that is an experiment I think for a lot of Black Americans that we hold in our memory. So that was a study that was sponsored by the U.S. Public Health Service. It spanned from 1932 to 1972, and essentially the whole goal of the study was to see what would happen to people if you left syphilis untreated. Yeah. And so they essentially enrolled these uneducated Black men in the South. They told them that they had bad blood. They never told them of the diagnosis. And even once a treatment, penicillin, had been developed, there were a portion of the participants that were never given the treatment, and many of them went on to infect their partners, and they developed advanced syphilis, secondary and tertiary syphilis, and even some of their children were born with congenital syphilis. And so, and this is a study that was, was federally funded, right? But this, again, I think people remember this study. And so when we're talking about even clinical trials today, right, and ensuring, adequate representation, I think specifically for this vaccine, it's important because we've been seeing the disproportionate impact that coronavirus has had on Black, Latinx, and Indigenous communities, right? So that's very important. Those efforts are important, right, to make sure we recruit a diverse representation of participants.
Well, I absolutely agree. And I spoke about it a little bit recently.
Yeah, you did talk about it on PBS.
No, it was in a magazine or.
Yeah, okay.
But I think the other thing, you started by saying the low percentage of Black physicians, right? And isn't it more likely that if you are Black and have a Black physician, there's more of a connection there, right? And the fact that a lot of people can't see a Black physician is an issue. So what's happening in medical education? I mean, that's a big.
You're like what's happening?
What's happening? Like, what are they doing? No, really. I mean, that's a big issue.
Yeah, no, definitely, it's a big issue, and the numbers haven't really budged that much over the last few decades. Even since my mom was in medical school, the numbers really of Black physicians haven't budged. What I do want to say though is that the same reasons that we have racial health inequities are the same reasons why we have a paucity of Black physicians, right? To get to medical school, you have to, one, be exposed to people who, there's role modeling, right? So, you have to have seen someone that looks like you, but also when we're thinking about how, because of policies like redlining, how communities of colors have been disinvested in, that impacts education. We know that property taxes go towards education, right? So if you are not receiving a high quality education, right? You're not exposed to physicians, you don't have the opportunity, another social determinant of health, for gainful employment or to purchase property, which is one way you accumulate wealth, right? You are probably going to be ill prepared and ill positioned to be applying to medical school, right? That may be something that's not even, that you wouldn't even consider. So, I think in terms of when we're thinking about bias and racism and addressing it, we have to think about just not the pipeline, right? The pipeline of people going into medicine, but also, the care that we're providing and how we're providing that care.
And, the past several months, the issues have been in the news a lot, right? So shining a light on it, which is very, very important. Having conversations like this, having conversations that we've never had before.
Right.
Frankly, in all parts of my life where we're talking about it. I guess what I want some guidance on, number one, is what are concrete things that we can actually do? Right? Many of the people on this call are in business, right? And the issues are no different there in terms of racial disparities.
Right.
What can we do in our organizations or with our friends?
Mm-hmm. Yeah, I think that's a great question. And I think that, we're in this very unprecedented and also transformative moment. I think that if we don't really talk about these issues now, right, if this is not a good time, then I don't know when it is, not just given the pandemic, but given, we've had the killings and or shootings of Black Americans over the last few months that have been, caught on video and obviously are very horrifying. And I think that, organizations really need to think about that. One, this is a long-term commitment, right? Like we are in the situation we are right now, where we have, a paucity of healthcare professionals of color and these health inequities, because we're literally centuries in, right? And so I think the first thing I need organizations to realize is that this is not going to change overnight, right? So it's going to take a long-standing commitment, but it also has to take intentional work. And I always say it starts with the leadership of whoever's leading the organization. That has to be a value and a priority, like anti-racism, right? Has to be a value and priority of whoever is leading that organization, because if it's not, that it ultimately trickles down to the rest of the organization. And then I think when you're thinking about strategic plans and practices and policies within your organization, we need to think about, are you using a lens of equity? I think a lot of times, people don't realize it. And another reason why I think, data is very important, but in terms of keeping metrics over who you're hiring, who you're retaining, who you're promoting, I think those are really key to figuring out what is happening within your organization. So, I admit, we all have our blind spots. For a very long time, I literally was the only Black physician in my department at NYU, and none of my colleagues said a thing. I'd be sitting in faculty meeting, but no one just said, hey, I noticed that, we need to do better, right? And so I'm hoping, what's been going over the last few months, that now I'm not going to be the only person to notice that. We need, folks that don't look like me to also, come on board and to make these, observations. But also, I think that, top down, looking at practices and policies, I think keeping track of the data, right, and seeing what are your goals, right? What kind of representation do you want to have within your organization in terms of women, in terms of people of color, right? And it has to be intentional. It cannot be an afterthought. And I think a lot of times organizations think by hiring a chief diversity officer, that is going to fix things. That is merely a Band-Aid. You cannot put centuries of work on one person, right? It has to be embedded in almost every role of the organization.
And well, your case in point, right? At NYU, you were in charge of diversity, and you weren't even enabled, right? You weren't.
Right. Yeah, I wasn't enabled, and what I actually realized is that I was essentially a figurehead. I literally thought, I think they were surprised. I think they saw me, they knew that I was very energetic and eager, and let's put her in the role, but they didn't actually think that I would actually want to push for change, that I would want to see Black faculty supported more, Black students supported more. And yeah, I mean, so I think, leadership of organizations, I think we need to think about how to give other people opportunities. I think what anti-racism work also involves is that, sometimes it's about giving people who have not been traditionally in that role a chance, right? And then also rethinking what are qualifications, right? I think, there's very rigid sense in a lot of organizations about, what are the qualifications we're looking for? What is a good fit? Right? Especially the good fit part.
Right. I love that you said that, because, when people say there's a great, you're the best person for the job, not to me, but to whomever, I'm like, because they were in a data set, right? If you're not in that data set, you don't even have a chance, right? There's no one right person. So the other thing I really liked and want to reinforce what you said is it's incumbent upon everyone to take a stand, right? I mean, I need to be cognizant of what's going on in my organization and take a stand, right? And point things out and, all of that. So I think it is, it's really incumbent for people to think about.
Can I just add that, like, you know, even
course.
like I just mentioned, like the good fit part, like, you know, like there are ways, like we know that having structured processes, like having, you know, predetermined interview questions or predetermined criteria to evaluate, you know, employees is really important, because a lot of times, whether we realize it or not, we bring our biases into these situations. And so you could be interviewing someone for a job and, hey, we went to the same high school, and you end up talking about that for half an hour, and you don't even have the opportunity to assess whether this person actually has the skills for the job, but they're a good fit, so we have to have them, you know, on our team, so we have to hire them.
Right. So here we're in New York City, and we just issued this report last week on the digital health ecosystem, right? The state of digital health. There, you know, we were curious, has COVID impacted that, right? Like in terms of funding in a negative way, and the exact opposite. I mean, there is more money going into digital health than ever before, like in the 7 months,
Yes, makes sense.
you know, more than all of 2019. So, okay, great. New York is the hub. But what can the digital health community do to further what we're talking about here? I mean, there are companies that we know about like CityBlock and Healthify,
Yeah.
but what else can the digital health community do? How do you envision working with them, or how could we?
Yeah, no, that's such a great question. And I actually think like digital health companies are the next horizon in terms of like the work that I do, because, you know, I think what I will say is this, like over the past like 50, 60 years, we've had such significant advances in healthcare technology that actually haven't closed the gap in racial health inequities. They've been very, very persistent. And so, you know, you would think technology, that means better care, better health, but not necessarily. And so I think that, you know, in this moment, I need these companies and leadership to really think about, you know, how are we making a difference? Like, are we using a lens of health equity where we're reaching the populations that need to be reached, right? The ones that are, you know, more disadvantaged. And so, you know, I think, you know, thinking about social determinants of health is going to be key, because we know that structural racism is a key driving force of the social determinants of health. Thinking about, you know, what communities are you engaging with? I think that that's also very important. And then ultimately thinking about looking at your metrics, you know, who are you targeting? What are the health outcomes needs to be important. So again, tracking that data and tracking progress is going to be key, because, you know, although we think of technology as something that it's more likely to help people, can actually be incredibly detrimental to health. Like, I don't know if you read that article last year in Nature magazine about that algorithm that I think several insurance companies were using to allocate resources for care. But, you know, when software developers are not thinking about their, you know, the unconscious bias that they have, there may be a detrimental effects to patients. And so there was this algorithm that actually calculated how much it would cost to take care of critically ill patients. And they allocated a lesser amount for Black patients than white patients. And they did this based on data that they had. But what they didn't take into consideration is that Black patients were not accessing healthcare because they couldn't get to their appointments, right? Because of, you know, communication. Like, there were other barriers to them accessing care. So it wasn't that they needed fewer resources, but this algorithm actually affected tens of thousands of patients. And so, and so these are the things that we need to think about. When I say, you know, we're talking about health equity, right? And thinking about whatever product you're designing, you want to make sure that, you know, that you're doing this work through a health equity lens. And I think even that telehealth, where, you know, some of these apps where you're using text messaging, what if people don't have like broadband access? Or also, what if they, you know, in terms of their educational levels, you know, are they able to understand what's being texted to them? Are they able to read it properly? So there are a lot of different considerations that need to be, you know, taken into consideration, essentially.
Our friend Gil Otto, who's the CEO of Rubicon MD, last week published an article on just that, that telehealth really should be the great equalizer, and it's not at all. And, you know, one of the social determinants of health is broadband, right?
Absolutely.
or yeah, Wi-Fi in your home. I mean, and then having a, you know, some sort of smart phone.
Right. I mean, we're even seeing that with the kids, like with schools.
Oh yeah, with
right?
schools.
I mean, we're seeing that there definitely already is this pre-existing, they call it achievement gap, but I like to call it like opportunity gap.
Yeah.
And that, you know, we're having this remote learning, but you know, if children don't have access to broadband, then they're not going to be able to do their work, right? And we're seeing these differences based on communities.
So, you know, thinking about COVID, right, and the whole vaccine and the vaccine trials got me thinking about, you know, development of drugs and devices, you know, through now. And I think, you know, historically, you know, these trials are very prescribed, right? And so, you know, the Black populations, Latin populations, you know, basically non-white populations haven't really been represented. How, going forward, you know, if there is this inherent suspicion, so the health system, going forward, what could companies do to eradicate that and make sure they are enable recruiting into the trials?
Yeah.
And with COVID.
Yeah, no, and you know, and I'm glad that I'm seeing like more of this discussion in the lay media. And I know that Moderna, like their phase 1 trial for coronavirus vaccine, literally, I think it was like 89% white participants. And I'm like, really? Like, no, but apparently I went to their website, they're doing a better job with this is the phase 3, and also Pfizer in terms of recruitment. And so, you know, given like the history that we talked about, given Tuskegee, and given also Henrietta Lacks, which some people on the call may know about her, but you know, she was a 31-year-old Black woman from impoverished Baltimore who presented to Johns Hopkins Hospital in the 1930s, I think, with metastatic uterine cancer, and her cells were actually taken from her without her consent. They're known as the HeLa cells. I used them in medical school in my histology class, and they were immortalized. So companies literally have made billions of dollars off her cells. Her cells are actually still being used now in research and development of the coronavirus vaccine. But, you know, so again, but these stories are really well known in our community. So people are like, I don't want to get involved in that. But what's interesting is a lot of the data shows that if participants are fully informed about the benefits of the trial to them as an individual, to their communities, like to the greater population, that actually Black and Latinx patients are more likely than white patients to sign up for the trials. Yeah, exactly. And so, but I think also part of it has to be about a nuanced outreach and messaging. So, you know, I spoke to you that I was working with a pharmaceutical company recently, and you know, I talked to them about really engaging with community-based organizations that are already on the ground in these communities doing the work and that are led by trusted leaders. And that can look like churches, that could look like YMCA's, neighborhood coalitions. But I think also the messenger just can't be the company. You have to, it's really about engagement and partnership with organizations that already are trusted on the ground doing the work.
And also with physicians. I mean, because physicians are often the #1 reason you enroll or don't enroll in a clinical trial.
Yeah, it's very true. Yeah, I'm actually going to be working, I have a contract with another company. I don't know if they're on the call, but they're a startup for clinical trials, but we're going to be talking about, because usually it's the physicians that are enrolling patients, and they're community physicians, and sort of how do they talk to their patients about, you know, how do they recruit them? But I also did want to mention that it's not just about, you know, the outreach and messaging, but also it's important to think about what do these participants need to be able to engage in the trial successfully. So is it because if they're working during the day, do we need to have, you know, after hours where the clinic is open so they could come and participate? Do they need resources for the bus or the train to actually get to the clinical site, right? So all of those things we actually need to think about, right? Like all the social determinants of health, it's all linked to, you know, whether or not these participants can engage with the trial.
So we have a bunch of questions coming in, and James Maisel, Zydoc, you've got a ton of questions. Keep it, keep keep it fairly short, James, but I'm going to allow you to talk, and you just need to unmute yourself.
Oh, okay.
Hi.
Hi, thank you,
Good
Bunny.
Yeah, okay, go for it.
Good to see you. Dr. Blackstock, you're doing a great job there, I think.
He's a doctor too.
Yeah, in IT and specifically the racial diversity became a big issue with the imaging. I think it's good to include everybody in the trials. Hopefully the COVID and everything will be there. You know, do you think that the affirmative action programs that started in the 60s, 70s in college and medical school were actually helpful? And
Yes, I
not,
do. Sorry, so I finished your question.
Yeah, if not, so you do. And
Well, the
why
reason,
don't we have more of that?
I'm sorry, say the last part again.
Why don't we have more of that?
Yeah, no, so that's such a great, I think it's a great question because, you know, actually I wrote a piece in the Chicago Tribune last November just about this because my mother was one of the first classes at Harvard Medical School to benefit from these, what they call diversity initiatives, but essentially were affirmative action policies. And, you know, and she was one of the first classes that had like, the largest number of Black students. And so, you know, I think obviously, as we know from history over time, you know, these policies have become, you know, incredibly controversial. But I have to say that, you know, I am a huge proponent of affirmative action. I think especially in healthcare, because we've seen what happens when we don't have, you know, healthcare professionals that look like their patients. We are having these very profound, appalling health inequities. And so I think that schools now, because of lawsuits, et cetera, you know, are definitely using, you know, different criteria in terms of evaluating students. But I know just from speaking to leadership, like at Harvard Medical School and a lot of the other medical schools, that this is definitely something that is a concern and a priority of theirs.
Mm-hmm.
Okay, thanks, James. Hopefully we'll see you in the not too distant future. Louisa Holland, how are you? I want you to ask a question, so you just need to unmute yourself.
Wow, I didn't think we'd get to actually talk. It's nice to see
I know,
Hi.
it's so great
Hi.
hearing people's voices. I thought you were going to
know.
read the questions out. This is great.
It's very well.
Wait, and you know what? Wait. You know what? Can you, for people who are asking questions, please just say who you are, like what you do, where you work. So
yes, that'd be great.
Sure. So I'm Louisa Holland, and I work with a company called VMLY&R, which is a major communications company, and we have a very large health practice. So we do a lot of communicating directly with physicians and with patients. And my question is around, you know, if you really wanted to get engaged in helping to solve, not that we have the ability to solve, but to try to solve or have an impact to improve some of the racial disparities in health specifically. I get your point that clearly if we had more Black doctors, it would be a lot better. And that's a very long game, right? To improve education and get more Black doctors. But in the near term, what would you say is the thing that we could do that would have the best impact clinically? Like where can we intervene to really help clinically today?
No, that is such a great question. And I also want to just make the point that we need all healthcare professionals like to be to have the skills to take care of a diverse patient population. So, you know, definitely, you know, having more practitioners of color definitely is one part of the solution, but obviously it's not the full solution. And so I think, you know, so some things that I said a little bit earlier, I do provide trainings, and I want to give just a disclaimer on the trainings. Like, I think one training is not going to make a difference. And so when I work with organizations and we talk about, you know, about racism in healthcare, and we talk about unconscious bias, and I give them strategies to work with, I also say that this is a starting off point for having conversations in your organization about how you're going to create structural change. I think that a lot of it can be, you know, about, you know, what's in your organization's strategic plan, looking at the practices and policies within your organization. And then I think in terms of direct patient care, you know, I do go over like debiasing strategies that people can actually utilize in their care. But I think also looking at, you know, metrics, looking at, for example, I worked with an emergency department that found that, you know, their Black patients were waiting 80 minutes longer to be admitted to the hospital than other patients. And so we actually went back in the whole process from when the patient arrived to when the patient's admitted to actually figure out, you know, where the lesions were. And then we came up with structured processes for addressing those lesions. So did physicians need reminders to go check on the patient again? And then we actually had a dashboard for providers to see how they were doing in terms of how they were caring for patients of different racial and ethnic backgrounds. So I think that, I know I gave you a lot, but I think that there is a lot of work that can be done all the way from your strategic plan to your practices and policies, all the way down to direct patient care. And I also always think that it's important to think about the communities that your healthcare professionals are engaging with, right? Or whatever product you have is engaging with. I think getting the perspective of people who use your product, people who come to your healthcare institution is incredibly important. And so whether you do that in terms of surveys, in terms of focus groups, in terms of interviews, you need to collect that data because you need to make sure that you're not missing potential blind spots. And then also, sorry, I said all these ideas. And then another thing is just even looking at metrics in terms of how different groups are doing in terms of their health outcomes, right? People who come to you, like, how are diabetic patients doing? How are patients with hypertension doing, right? I know a lot of organizations are doing that and then just aggregating it by different demographics, not just race, gender, socioeconomics, to actually seeing, like, you know, is everyone receiving equitable care?
That's great. Thank you.
Sorry.
Thanks.
Louisa's a fellow alumna, by the way.
Okay.
A little older than you, but yes.
All right, Toyin.
Oh, is that my Toyin?
I don't know if it's your Toyin. Hi, Toyin, you just need to unmute yourself.
Okay, can you hear me?
Yeah.
Yes.
Oh, okay. Hi, this is Toni Diami. I'm an infectious disease physician here in Chicago, and excellent today. Just following your work and listening to you today, it's been really excellent. So I'm in HIV and was in academia for 20 years and more recently now in pharma, still looking at doing HIV work and disparities work. And again, just the points you made around, and I have a daughter who's applying for med school, and again, the numbers haven't changed. 28 years later, 5%, and you know, how many make professor? So again, it's important to keep doing that work. My questions were, one, around the role of peer navigators and community ambassadors in doing the messaging. So we do that with HIV and in prevention, actually people from the community, and you know, granting them employment, having them be part of developing the message, how it's delivered, who's going to deliver it, and having them be part of that. And the second point is, how is your organization looking at showing these companies, including healthcare institutions, the incredible financial, I mean, let's forget the altruistic and the moral reasons to do it, financial advantages of having a diverse leadership. I'm not talking about the workforce, because a lot of places will put out their metrics and their numbers and put, you know, we have X people of color, but when we get to the leadership, the number is really low. Right. So how do we show them the financial benefits of having leadership that has a diverse lived experience?
Right. Yeah, no, it's just such great questions. And on the last point, I may need your help because I personally, like, philosophically try not to bring up the financial part. Of course, here I am talking to business leaders. You know, I mean, I just feel like, what better argument than talking about life and death?
It's
like,
the right thing to do.
Yes, I mean, I don't know what more you need. So we should talk after the call. But I'm glad that you also brought up the piece about community navigators. I actually wrote a piece in the Washington Post a few months ago about community health workers. So I think it's sort of the same idea, but really engaging people in the community, offering them a source of employment, but also using them not using them, but having them actually lead us in terms of the work that we're doing within their communities. And I think that's something that is very underutilized. And so I'm glad that you brought that up, Toyin.
Great, thank you.
Thank you. Thank you.
All right, here's one from an anonymous, wants to be anonymous. How would you advise DE&I leaders to balance the historical need to focus on racial equity with contemporary demands to add other groups to the DEI conversation?
Yeah, no, hey, so that's a great question. And what I will say, and I'm going to be very transparent about this, I think when you look at the racial health inequities and you look at sort of the legacy of racism in this country, what I will say is we have seen like the most detrimental impact on Black communities, and that we actually, we are essentially, slavery was the beginning of the this country. And so while I think it's important to bring in other groups, I think we need to do so while acknowledging the history, and also acknowledging that when you bring up the groups that have been most detrimentally affected, everyone benefits from that. But I definitely understand that this is probably a more complex and complicated effort to address, and I do think that everyone's voices need to be heard. But I think we need to think about the historical context and what we see now as a result of that history.
Okay, next up is Joe.
Joe connected us.
Yes, Joe connected us. You're the connector.
I'm the connector, thanks.
Thank you, Joe.
Nice to see you, Dr. Blackstock and Bunny. Yeah, so I was thinking about some of the places I've been. So I'm a healthcare IT founder, and now I guess I'm in the connecting business. And I was just wondering.
You're very good at it.
It's a good business.
I love doing it. I was just wondering from the local perspective, to the extent that network access and bandwidth is a factor for telehealth, are you plugged into the New York City CTO, and are you plugged into their internet master plan and what's happening with that?
I am not, but I have a feeling you will connect me.
I certainly will.
Thank you. No,
I just put a link to the plan. It's John Paul Farmer in his office, and I will definitely reach out to you both on LinkedIn. Thank you.
Thank you.
Okay. Ada has, if you would unmute Ada,
Right.
Hi, can you hear me?
Hi.
It's Ada.
We can. And Ada, tell us where you're
Ada.
Brian Lair. Tell us where you're calling from and who what you do.
Okay, hi, Dr. Blackstock. My name is Kaffwa. I'm calling from Philly. I'm actually an attorney and I practice in the health law and employee benefits space. So I saw this on LinkedIn. I come from a family of doctors, but I did not go that route. But I saw this post on LinkedIn and I was just like, this sounds really interesting. I'm interested in this area. So I have kind of two questions, not really related, but maybe. So at the beginning of the pandemic, there was, I don't know if you were aware, but there was this rumor going around that, Black people were somehow immune from COVID, and that it was basically like a white person's thing. And now the story has like completely switched to Black people are, disproportionately impacted by COVID. Yeah. And so do you think that this like Black myth kind of played a factor in the disproportionate numbers we're seeing now amongst the Black community? And then also, do you know if the COVID numbers, when we talk about the Black community kind of as this monolith, it's not, but do you know if the numbers are broken down between African Americans versus Africans versus Jamaicans and Caribbeans? And I asked that I'm African, full disclosure, coming from that community, that I think that myth is even more so there that, COVID does not affect Africans. And so I'm just wondering your take on that. And then I can ask the second question.
Yeah, no, so that's such great questions. So yeah, no, actually I did hear about the myth that Black people could not be infected with COVID. And there was also another myth about 5G cell phone service being implicated in COVID infections. But anyway, but I think what happened is that, you know, I think part of this like distrust that we've been talking about, you know, that is, you know, historical and definitely valid and just, I think definitely that probably influence some of these myths that we are hearing. However, you know, I think it's hard to say and hard to quantify what effect that actually had in terms of, you know, the COVID morbidity and mortality, because what we do know is that there were factors like the fact that our communities have a higher burden of chronic disease, that we are more likely to take public transportation, we're more likely to be essential and service workers, we're more likely to live in overcrowded housing, that we're more likely to be factors involved in the disproportionately high rates that we've seen of COVID-19. And I want you also to know that I have not seen any breakdown, and I've been keeping a meticulous track of this, but I haven't seen any breakdown looking at these rates disaggregated by like ethnicity among Black people. I haven't seen like Afro-Caribbean, African-American, or African from the continent, but I think that would be a very interesting study to do. And you had another question.
I did. Thank you for answering that first one. And so the second question, you know, you talked about this, it seems like this surgence of chief diversity officers and inclusion officers at different organizations in the wake of, you know, the George Floyd protests and just these nationwide protests and companies showing solidarity and things like that. But I was wondering, sometimes, I mean, even at my law firm, we do a lot of diversity training, and I just wonder whether that kind of falls on deaf ears and whether it makes more sense to do this at the beginning of the pipeline. So do you think that it would help if, and I don't know, please correct me if I'm wrong, if medical schools...
My kids just came home, so if you hear kids, sorry.
Hi.
No problem at all.
Sorry.
If medical schools, you know, would do a better job educating students about maybe some health concerns or diseases specific to communities of colors, I'm thinking like sickle cell or lupus, or maybe do implicit bias training as part of the curriculum, do you think that that would have a more impactful outcome than already teaching people who are already like coming out, than already doing these type of trainings when people are already set in their ways and have been practicing medicine a particular way for so long?
Yeah, no, I think that's, yeah, no, thank you. I think that's an excellent point. I think that I will say that in my experience is that Black students and other students of color have been the driving forces at medical schools to really change the curriculum to ensure that these issues, that racism, unconscious bias, is being addressed as early in education as possible. Because I do agree, like once you go through your medical school and once you go through your training, and then all of a sudden you're having these trainings, you know, it's really hard to create change, right? Because you've already, I know the process, you know, these values and priorities are instilled in you every step of the way. And I agree. I would say even before medical school, I mean, this needs to be a part of early childhood education. I mean, it's you know, obviously it is very heavy, you know, material, but I think that one of our paths forward is really discussing this and being more transparent about our conversations about racism.
So we're just about out of time.
Okay.
Before we leave though, I usually ask people, what makes you hopeful? What makes you hopeful about the future, that, you know, all the work you're doing?
It's a great question. I think by nature I am an optimist. I'm an optimist. But I also think that, especially in this moment, as I mentioned, it's an unprecedented moment, and we're having conversations that I mean, I'm going to be 43. We haven't had in my lifetime, and we're having them in a very candid and open way. And so I'm hoping that out of this moment that we can create some change that will actually benefit everyone. I think what people don't realize is that racism harms all of us, right? It harms all of us in multiple ways, whether we realize it or not. And so I think instead of shying away from these, you know, uncomfortable topics and conversations, we really need to embrace it.
Well, I want to thank you so much for spending
you.
time with us. We are incredibly lucky to have had you, and I feel really lucky to have gotten to speak to you. And we will we'll look forward to reading and hearing from you in the future. But hopefully the folks on the call got some very specific ideas about how they really can move forward, and really appreciate your time.
Thank you so much. And thank you everyone who stayed on. Thank you so much.